Hi everyone, I'm Dr. Roman and I'm a hematologist oncologist, and today we're going to talk about pancreatic cancer. Very important topic. If you or someone you love has been diagnosed with pancreas cancer, you need to watch this video. You know, I'm treating cancer patients all day long, and I can't tell you how many times I have a patient and their family in the room with me and they have no clue what's going on. It's unacceptable. Listen, this is an important topic. I'm going to throw a lot of information your way, but you need to know this. So I'm going to ask you, grab yourself a cup of coffee, grab a little notepad, make your own notes. I'm going to throw a lot of info at you. We're going to talk about the anatomy of the pancreas, different types of pancreas cancer, how they present, the symptoms, how to make the diagnosis, imaging, chemotherapy, surgery, everything that you need to know for pancreatic cancer. This is dedicated for patients, okay, or nurses. This, us oncologists, we need to know a lot more than this, but I guarantee you, if you tough this out, you will know what questions to ask. You will have a good concept as to what is going on. So with that being said, let's get started. I'm just going to ask you for one little favor. If you find this video useful, please subscribe, leave a comment, like. It lets me know that you are deriving benefit from this, and it motivates me to make other videos for other cancer types to help other people. All right, so please subscribe, leave a comment. I love to hear from you. Give me some input. All right, now let's start off with the anatomy of the pancreas. So this in yellow, the organ in yellow, is your pancreas. This is your small intestine. This is the gallbladder. Over on this side, at the tail end of your pancreas, you will have your spleen. This middle portion that you see here, this is the main pancreatic duct. So all the pancreatic enzymes that are made that have to do with food digestion are made in the pancreas, and they go into the main pancreatic duct, and then this is secreted into our small intestine where it meets the food that is coming from the stomach. That's important because that's what aids in our digestion, the breakdown of foods in order for our body to be able to absorb them. Now, the important thing about the pancreas is that it is deep within our abdominal cavity, and it's surrounded by blood vessels, arteries, and veins, as well as this green tube here, which will come down and also dump the bile into our small intestines. And the issue with a pancreas cancer, depending on where it's located, it can invade these blood vessels, arteries, and veins. And in doing so, if they significantly involve a major blood vessel, then that will render your pancreatic cancer unresectable. That's important to keep in mind when we go over the surgical portion or the treatment portion of your pancreatic cancer. Just know that the pancreas is divided into the head region, the neck, the body, and the tail. This is important because depending where your cancer is, your symptoms will depend, depending on where it's found, and depending on where that pancreas cancer is found, also will render what type of surgery you will require. So you also need to keep this in mind. So, for example, if your tumor is found in the head of the pancreas, you will require what they call a Whipple surgery, where they cut out the head of your pancreas, also part of your small intestine, your gallbladder, and they will reconstruct this all, and they call this a Whipple surgery or a pancreatoduodenectomy. If you have a cancer in the body or the tail portion of your pancreas, over on this side, then you will require a distal pancreatectomy. Well, they will remove this part of your pancreas, and the majority of times also your spleen. And we're going to go over this in a lot more detail. All right, so before we continue, I'm going to ask you to read my medical disclaimer where, I'm providing this for educational purposes only. I am not your physician. I am not providing medical advice. So just some basic information of pancreatic cancer. Know that there are different types of pancreatic cancer. For example, neuroendocrine tumors. There are others. Those are very uncommon. I'm going to talk about pancreatic adenocarcinoma, which is by far the most common form of pancreas cancer. It's found in about 85% of pancreas cancer cases. Now, there are different subtypes of adenocarcinoma. For example, the acinar cell carcinoma or the colloid carcinoma, which are a little less aggressive. They're still aggressive, but they have a little better prognosis. And there's also another subtype, the adenosquamous carcinoma, which has a worse prognosis. Every person with pancreatic cancer has a different type of symptom depending on where the cancer started. The most common location is the head of the pancreas, and the typical triad that patients present with is pain, jaundice, which is the yellowness, and weight loss. The pain can be, it can present in different type of ways, but the most common presentation is epigastric, or a pain in the middle of your abdomen that radiates towards the back, towards your back area. It tends to be worse when you're lying supine or when you're lying in bed facing up, and laying on your side tends to make it a little bit better. Also, the tenderness tends to increase if you eat. The weight loss can be quite dramatic. At the beginning, it's a weight loss and you don't know what's going on. So if you ever see somebody that's having continued weight loss and they're having pain, especially in the middle of their abdomen radiating towards their back, you have to think of the possibility of a pancreatic cancer. And if they're developing some yellowness to their skin or the yellowness in the eyes, you need to get worked up as soon as possible. In the body and the tail of the pancreas, most patients do not develop symptoms until the cancer is very advanced, and usually the presentation is going to be pain and weight loss. Because remember, if you go back to the anatomy, the common bile duct and the gallbladder, that area is on the head of the pancreas. So usually at the beginning stages, you will not develop jaundice when the pancreatic cancer is in the body tail. That usually implies it's in the head of the pancreas. So the location of the pancreatic cancer, about 60 to 70% of the times, is located in the head of the pancreas, 20 to 25% in the body and the tail. Now, the most common places that pancreas cancer likes to spread to is the liver and the peritoneum. The peritoneum is just our abdominal cavity, the whole area around the pancreas. The lungs and the bone can happen, but it's much less frequent. I wanted to throw this in here because this is very important. I've actually seen this quite a bit. Pancreas cancer is known as a hypercoagulable state. All that means is that it increases your risk of blood clots. So if you ever have a person or you meet a person that had a blood clot, especially in the legs or in the lungs, and they don't know why they developed this blood clot, just know that pancreas cancer is a possible cause. The usual way that I've seen it is a person that's been losing a lot of weight, they have some abdominal pain, and they present it with a blood clot. Just thought I'd throw this in here. So laboratory studies. So every pancreas cancer patient at a minimum should have a CBC. You want to know how their white count is, their hemoglobin, their platelets. A CMP, which stands for a complete metabolic panel. This is looking at their liver function, their kidney function, their electrolytes, their protein, calcium, potassium, etc. Also an amylase and lipase. These are markers of pancreas inflammation, so you definitely want to see these. As well as these two cancer markers or tumor markers. The first one is a CEA. The next one is a CA19-9. Now the CEA is very non-specific. You can see this in smokers, or you can see elevations in smokers and in many different types of cancer. For example, colon cancer, gastric cancer, prostate cancer, breast cancer. I can't tell you how many different types of cancer. The CA19-9 can be seen in multiple cancers, but it's usually seen in cancers of the pancreas, the gallbladder, or the biliary tree, what we call a cholangiocarcinoma. That's the typical location. And the take-home message here is CA19-9, just like the CEA, is not specific. I have to tell you, I have seen multiple patients with an elevated CA19-9. Years have gone by, and I have not found a cancer. So just keep this in mind. Things like gallstones, pancreatitis, or stones in your gallbladder, pancreatitis, an infection in your biliary tree, all these things can elevate a CA19-9. Now, how do we make the diagnosis? Well, of course, if you present with symptoms, the next step will be the labs, and then we will perform some type of an imaging test. The most common types of imaging are ultrasounds or a sonogram, the same thing, a CT scan, an MRI, or a PET scan. So let's talk about an ultrasound. An ultrasound is a pretty good test to look at the liver. Now, it's not a very good test to look at the pancreas, especially the transabdominal ultrasound, like when a woman is pregnant, the same type of test. They put that jelly on your skin, they move this probe around, and they're looking at your pancreas. It could detect a pancreatic cancer or pancreatic mass in the head of the pancreas if it's greater than 2 centimeters. In the body and the tail, it's not very good. You can easily miss a mass. Overall, an ultrasound is not a very good test to look at the pancreas. A CT scan, on the other hand, is a very good test, and you will need a CT scan with IV contrast. In other words, that iodine contrast. There is another type of CT scan, which is called a multi-phase CT scan, or a CT scan pancreas protocol. That's a very good test to look at the pancreas, and what they do is they inject you with the dye and they look at the pancreas in different stages of the time that they're giving you the contrast. So again, it's called a multi-phase CT scan of the pancreas. You have to have the intravenous dye, or the other name is a CT scan with a pancreas protocol. Very good test. You can look at the pancreas, you can look at the surrounding tissue, it'll help you find metastatic disease. In other words, if the pancreas cancer has spread to another area of the body. The other test is an MRI scan. There's another type of MRI that's called an MRCP. Very good test for the pancreas. So either a CT scan with contrast, preferably the CT scan pancreas protocol, or an MRI pancreas protocol, MRI with IV contrast, or an MRCP. Very, very good test. A PET scan is also a pretty good test, but a PET scan is more for advanced disease. It's pretty good at looking for disease in your liver, for disease in your lungs, but it's not such a great test to study the actual pancreas and to see if you have involvement of the blood vessels that we spoke about before. Because remember, in order for the surgeon to determine if you're resectable or not, they're going to have to evaluate the blood vessels around the pancreas. And for that, the CT scan or the MRI with contrast are way, way better tests. The other test we're going to talk about is an endoscopic ultrasound. Very good test, but this is an invasive test. They're going to perform an endoscopic, they're going to go in your mouth through a tube, like when you're having an endoscopy, and then they're going to insert an ultrasound probe. Now, the stomach is here and the pancreas is touching up against the stomach. So when they go in with that camera and it's the ultrasound probe, they can look at the entire pancreas with that ultrasound probe, and that's called an endoscopic ultrasound. It's different from the transabdominal ultrasound, very different. The endoscopic ultrasound actually gets very good pictures of your pancreas. The downside is you have to go in, you have to be put under with what they call conscious sedation. Like, if any of you have ever had an endoscopy, it's the same test, but they use a sonogram camera to get pictures of your pancreas. The other thing about an endoscopic ultrasound is that they can also obtain a biopsy of your pancreas, what they call an FNA, a fine needle aspirate. They can do different types of procedures, but in other words, they can go in, find the little area or the tumor, put a needle in it and aspirate some fluid or get a piece of tissue, etc., to send it for analysis. The CEA and the CA19-9, which we already spoke about, I can't tell you enough how many patients I have found that have elevated tumor markers and they do not end up having cancer. So just know you cannot fully rely on these. I have had patients that have a normal CEA and an elevated CA19-9. Most of the times, most patients who have pancreatic cancer, I have noticed that their CA19-9 is elevated, but again, not completely reliable test. I can tell you a place where I like to use a CEA and a CA19-9 if elevated. When we start you on chemotherapy, as the tumor shrinks, your CEA and your CA19-9 tend to go down. So they're pretty good markers of, how are you responding to therapy? But overall, we got to be very cautious with these tumor markers because they're not specific. Okay, so the most important question we're getting into, guys, wake up. I need you with me. The most important question you want to ask your doctor is this cancer resectable? In other words, can the surgeon go in there and take it out? And overall, it's divided into 3 basic types. Number 1, potentially resectable. In other words, on the CT scan or the MRI or the endoscopic ultrasound, you know what? It looks like, yes, the surgeon can go in there and take it out. Or borderline resectable, meaning, we're looking at these films, the pictures, the MRIs, the CAT scans, etc., and we're not sure. There's a good chance that it might not be resectable. Or we're looking at the picture and we can tell that it is unresectable. We cannot perform the surgery. And that's important because that question, once we answer that question, then we can start a treatment plan. So remember, the first question you're going to ask your oncologist is this thing resectable? And remember that unfortunately, the only potentially curative option for pancreas cancer involves surgery. Surgery is by far the most important treatment for pancreatic cancer, period. And that's why I'm telling you it's the most important question to ask. So what determines resectability? In other words, what would make your tumor resectable or unresectable? Well, obviously, if you have metastatic disease, if you're unfortunate enough that the pancreas cancer is, for example, in your bone, in your liver, in your peritoneum, which is your abdominal cavity, obviously you're not going to take out the pancreas because you cannot take everything out. So why put you through a major surgery? If you have lymph nodes involved outside of the area of surgery, then it's unresectable. If you have, remember when we went over the anatomy of the pancreas, if you have major blood vessel involvement, the pancreas cancer is eating away, it's grabbing, it's biting some of these major blood vessels, then it's unresectable. Not always. Some surgeons can still perform the surgery even if you have some blood vessel involvement, but it does make it a lot more difficult. And these are the cases that we call borderline resectable that we already mentioned. So this decision is made by your surgical oncologist or your pancreatic surgeon. The question that we get asked a lot of times, so let's go back here because I don't want to lose you. When a person first presents with a pancreas mass, so you had your CAT scan, you had your MRI, whatever case may be, and they found a mass in your pancreas. Remember, this is a picture. We cannot 100% tell you, yes, this is a pancreas cancer. A lot of times we can be 99% sure, but it's impossible to be 100% sure without tissue. So sometimes we ask ourselves, you know what, should we do a biopsy? And this is a question that you should ask your doctor. You know what, doc, if you have not had a biopsy done, should you have a biopsy done? And there's in general 2 common ways that we obtain a biopsy. Number 1, remember when we went over the endoscopic ultrasound, that the FNA or the biopsy, that's one way, and that's actually the most common way that a biopsy is done. Or the other way is a percutaneous biopsy. In other words, they find the mass and they go through the skin into the pancreas and they get a biopsy. Or if you have a mass in your pancreas and you have several masses in your liver, they can also do a percutaneous biopsy in your liver to see if that's pancreas cancer that you have in the liver. Overall, the fears of a biopsy are, of course, infection and bleeding. That's always a potential a risk. If you biopsy the pancreas, you always have the risk of developing a pancreatitis. Because remember, the pancreas has their digestive juices. If you take a biopsy, a sample of your pancreas, some of that digestive enzymes can leak out and it can cause inflammation of the pancreas. But one of the main fears is, could you spread the cancer cells? It's what we call seeding in oncology. Available data says that the risk of seeding is actually quite small. It's not a very high risk if there is a risk. And overall, the biopsy by an endoscopic ultrasound carries a lower potential risk of seeding. Percutaneous biopsy, according to the literature, has a slightly higher risk. But overall, just know that the risk of seeding from a biopsy is quite low. A biliary drain. Again, these are all questions, guys, that, might pertain to you. They might not pertain to you. So let's say you have a person that is yellow. The bilirubin is going up. That pancreatic cancer is obstructing your biliary drain, your biliary duct. The question is, what should we do about this yellowness of the skin? And there are things we can do. For example, they can put in a stent. They can go in and through, an endoscopy or what they call an ERCP, they can go in and put in a stent, so it'll open up your biliary drain and your biliary duct, and you can drain this bile. Or they can put in a percutaneous drain. That's a drain through your skin with a little bag on the outside of your body, draining out this greenish colored fluid, which is bile or biliary salts, if you will. There's pros and cons to each. So, something for you to discuss with your oncologist. If you're not yellow, if your bilirubin is good, then you don't need this procedure. Now, if your bilirubin is very low, let's say you have a little bit of yellowness going on, but your bilirubin is not very high, you may not require this. If you're going to go for chemotherapy first, they may recommend putting in a biliary drain. So if you are yellow, or if you have a high total bilirubin level, then ask your doctor another question to ask: do you need your bile system drained? In other words, do you need a stent or do you need a percutaneous drain? Chemotherapy. We're going to touch up on chemotherapy in the next few slides, but I want you to know this nomenclature, because you're going to hear your doctor talking about this. In chemotherapy in general, we have 3 different types, although I mentioned 2 here, but 3. Neoadjuvant, adjuvant, and then palliative. So neoadjuvant means they want to give you chemotherapy before surgery. Adjuvant chemotherapy means they want to give you chemotherapy after surgery. And then palliative chemotherapy means you have disease that's uncurable, it's unresectable, it's metastatic, and they want to give you chemotherapy to prolong your life. That's important. This is all important to know, because your doctor is going to have this discussion with you and you need to know. So remember, and I'm going to tie this all in at the end. Don't get discouraged. I know I'm throwing a lot of information at you, but at the end, this is all going to make sense to you. Remember, neoadjuvant before surgery, adjuvant meaning after surgery, and palliative meaning it's uncurable. We just want to give you chemotherapy to prolong your life and to try to make you feel better. Now, the different types of surgery. Remember, depending on where the pancreas cancer is located will depend what surgery you require. If it's in the head of the pancreas, then you will require a what they call a pancreaduodenectomy, or a Whipple surgery, where they resect the head of the pancreas, a piece of small intestine, your bile, your gallbladder, and part of your stomach, and then they tie everything in, and then they remove that section where the cancer is located. There are different types of Whipple. For example, pylorus sparing Whipple. There's different types of Whipple, but overall, it's just removing the head of your pancreas. A distal pancreatectomy is taking out the body or the tail, or the body and the tail of your pancreas, and the majority of times they remove the spleen as well. This is for tumors in the body and the tail of your pancreas. And last but not least, total pancreatectomy. This is seldom done, but sometimes patients have a very large tumor and they may require a total pancreatectomy. The bad thing about this is that it has a lot more morbidity and mortality. Although surgeries have gotten a lot better, just know that a total pancreatectomy will make you a type 1 diabetic, and it's something we try to avoid, but on rare occasion it might be necessary. Now, surgery can be done open or minimally invasive. Open is a laparotomy. They make an incision and they go in and they do their surgery. Or minimally invasive. Now, minimally invasive, there's two basic types. Number one is laparoscopic, where the surgeon is at bedside. They have these probes inside of your abdomen and they're doing the surgery there. The other type of minimally invasive is robotic, where you have arms. It's a robot with their arms inside your abdomen. The doctor is sitting on a desk on a computer and they're performing the surgery that way. The laparoscopic uses, in general, a two-dimensional camera, whereas robotic, a three-dimensional camera. You know, the good thing about the minimally invasive is that it's the healing is a lot better. The scarring or the incisions are a lot smaller, but the surgical time tends to be longer. For the most part, I've spoken to several surgeons, and open surgery is quicker, and a robotic or minimally invasive or laparoscopic tends to take a little more time. So, you know, some pros and cons there. The important question to ask is, which surgery does your surgeon feel most comfortable with the location of your tumor? Remember, it could be anywhere. It can invade any different type or multiple structures. So you want your surgeon comfortable. Rely on their experience if you need to get a second opinion, but do not force a surgeon to perform a specific type of surgery. Remember, you want to make sure that they are comfortable performing this surgery. I have had patients that have had open Whipples and they've done great, or minimally invasive and the patient has not done so great. So minimally invasive is not always the best answer, just something to keep in mind. Now, with all things being equal, of course, I'll take minimally invasive over an open. But if my surgeon were to tell me, you know what, I really think we need to do this open, it's in your best interest, I would really listen to them. Chemotherapy. So there's many different types of chemotherapy. And at the end now, the next slide, I'm going to tie everything in for you. So don't panic. I know I'm throwing a lot of information. A lot of you are lost. You may need to go back and listen to this again, but I'm going to tie it all in. So just know that there are many different types of chemotherapy regimen. These are the most common. So the first one is called FOLFIRINOX. It's a fancy name. It's a bunch of different chemotherapy agents used together. For example, 5-FU, irinotecan, leucovorin, and oxaliplatin. This is one of the more aggressive chemotherapy regimens. The side effects really depend on the person. If you're strong enough and you have your organ function, your kidneys, your liver, everything is pretty good, then you might be a candidate for FOLFIRINOX. It's given in the vein. 5-FU tends to cause some diarrhea. It can cause some mouth ulcers. Irinotecan, diarrhea. Oxaliplatin tends to cause some neuropathy, or when you drink something cold or you touch something cold, it can shock you. So you got to be careful. Your oncologist will tell you all about this. But very good regimen. It's pretty aggressive. Nalirifox is another regimen similar to FOLFIRINOX. It's another pretty aggressive regimen. It has, notice a lot of these are similar. It has 5-FU, liposomal, irinotecan, leucovorin, and oxaliplatin. So similar side effects as FOLFIRINOX, but it's another regimen commonly used, very good regimen. Another regimen is gemcitabine and nab-paclitaxel. Very good regimen. This one tends to be a little more mild, if you will. Still very good chemotherapy, and it's another regimen that we tend to use. And I've used actually nab-paclitaxel in a patient that had received, for example, FOLFIRINOX, and they didn't do very well with FOLFIRINOX, but yet they did very well with nab-paclitaxel, and vice versa. So, you got to really use common sense, and I just want you to know that there are different options, and one might work better than the other in your specific case. This is a discussion to have with your oncologist. Believe me, your doctor will mention all these regimens for you. There's also another type of drugs that we call targeted therapy, and this is very important. This is more for metastatic disease, so if you have or unresectable disease. But for the most part, patients with pancreas cancer will get genetic testing done. And there's two types of genetic testing, and I'm going to ask you, find my video in my channel on genetic tests. But there's germline testing, meaning hereditary genetic testing, that we're trying to find to see if you were born with a genetic mutation that predisposes you to cancer. And the other type of genetic testing is somatic testing. And just know, the bottom line with genetic testing, we want to know if you have a mutation that can be a potential target for treatments that we have. And I'm just going to name a few. You don't have to know this. But for example, if during your genetic testing or your tumor testing, somatic testing, many different names we give these tests, if we find a specific mutation, maybe you'll be a candidate for immunotherapy. Or you might be a candidate, for example, if you have a BRAF mutation or an NTERT mutation, or there's so many out there. Just know that we have treatments for specific mutations. So you may want to ask your doctor, hey doc, are you going to test me for genetic testing, both germline and somatic? This is more for metastatic disease, like I said, but sometimes it's worthwhile doing it in the more resectable types of pancreatic cancer. Now we're going to tie it all in, okay? So this is a quick recap. I'm going to tell you what you need to ask your oncologist. So the first question, they found a mass in your pancreas. You probably had some symptoms, maybe pain, you were turning yellow, weight loss. Those are the common. There are others. They did some sort of a CT scan or an MRI. They found this mass in your pancreas. They did blood tests. Maybe your liver functions were a little high, or your tumor markers were a little high, whatever the case may be. The first question, is it resectable? Remember, potentially resectable, borderline resectable, or unresectable. If it's potentially resectable, okay, the surgeon says, yes, we can take this out. The question is, should we give you chemotherapy first, or should you go to surgery first? And that's a discussion to ask your doctor. There really is no good data, although the majority of the times now we're starting to give chemotherapy first, meaning neoadjuvant chemotherapy first. But sometimes some institutions, some surgeons prefer doing the surgery first and giving the chemotherapy after, meaning adjuvant. See, now you know these terms a little better. Now you can have this discussion with your doctor. If your doctor tells you it's borderline resectable, then yes, chemotherapy first, absolutely. Usually we tend to go with the two more aggressive regimens like the FOLFIRINOX that I mentioned before. But that, chemotherapy first is usually the way to go. And the reason for this is studies are showing that if you're borderline resectable and you have chemotherapy first, you tend to get negative margins a little better. In other words, when the surgeon goes in, they tend to be able to take the tumor out. The lymph nodes tend to be negative a little more often if you receive chemotherapy first, and the outcome tends to be a little bit better. Whereas if it's unresectable, then surgery is not an option and chemotherapy is what they're going to give you. Remember to check your labs. We already went over this. If they decide to give you chemotherapy, you will require a port. That's, it's basically a catheter. It's put on your chest wall, either the right side or the left side. It's under the skin. So we can give you the chemotherapy in the port and not in the veins of the arms. I already mentioned the genetic testing. Ask your doctor if you require genetic testing or not. Decide on the chemotherapy drug. This really depends on how strong you are. If they're going to give, remember, now you know neoadjuvant versus palliative, which chemotherapy regimen, the more aggressive versus the less aggressive. There's many different types. And last but not least, radiation. Radiation in pancreatic cancer is not really frequently used unless, I'll give you some examples. You go to surgery, they take it out, and they were not able to take out the whole tumor, but it has not spread, meaning it's localized to the pancreas, but you still have tumor there. They may consider giving you some radiation. Also, let's say you have pain in a specific location, they can give you radiation to help alleviate the pain. So radiation, you can ask your doctor, but that's not very frequently used, although it does have its indications. The last thing I want to mention is pain is a big deal in pancreas cancer. A lot of patients have pain. A lot of times I'll recommend you see a pain specialist. Just know that there are patches, there are pills, and there's also something that's called a nerve block. They can go in there with a needle, they can inject your nerves, and I have had some patients tell me that the nerve block has really, really helped them out. So I hope you found this helpful. I know it's a lot of information, but you need to know this, guys. I mean, you cannot go blind to your oncologist and just be at their mercy. You have to be able to ask the appropriate questions. So remember, subscribe, and I wish you the very best.